life-threatening events. Who's seen one of these in their emergency department? Or who thought they might have seen one? Who's not sure they might have seen one? It's a really difficult area, okay? So here's case one, an 8-month-old baby born at birth, born at term, brought in by parents because they're concerned. And this is a scenario. The baby had an episode of coughing. Then, according to the mother, stopped breathing, went limp, blew, made a grunting noise, started breathing again, it was fine. Only happened once. The history is really the key when you're dealing with Alte, okay? So, coughed, stopped breathing, limp, blew, grunting noise, breathing again was fine, 8 months old. We'll revisit it towards the end. Is this an Alte? Who thinks that's an Alte? Who doesn't think it's an Alte? Well, hang on, you either think it's an Alte or you don't think it's an Alte. Seriously, this is what comes into your emergency department. Okay, that's what you've got. That's the history. All the parameters are normal, okay? Everything is normal. Mum and dad aren't drug addicts. There's no non-accidental injury. There's nothing else in your brain. And that's what you see. This is really important. This is where we've got to commit. Who thinks this is an Alte? Hands up. Okay, so the rest of you should now put your hands up. Who thinks it's not an Alte? Okay. I won't pick on you. We'll go through at the end of the lecture. But it's really important, and there's one or two discriminating things in this story that help you go one way or another. Case 2, a 1.5-month-old, born at term, brought in by parents. Born at term is very important because you have to correct for that if they're a preemie. Born at term, brought in by parents. After feeding, the baby seemed to gag, stopped breathing, went limp and blew, made a bloody grunting noise, and then started breathing again. It was fine, and this is the only time it happened. Who thinks this is an Alte? All the parameters are normal, yeah? Who doesn't think it's an Alte? Okay. So, go home. Who would send this patient home immediately? Right? Who would send this one home? Cool. Excellent. All right, let's keep going. Okay. If the kid's limp, if the kid's blue, if the kid's decompensated, I'm in my element. Okay? I can resusc you to the cows go home. The kids that worry me are the kids that look good now, but something happened when I wasn't there to see it. And I have to rely on somebody else, not the person it happened to tell me what happened. That upsets me. Okay? And so I've got to find some way of getting mum and dad to tell me the story, at the same time taking out all the stuff that's going to be very emotive, because this is their child, they're concerned. You know, he seized. How long did he have a seizure for? Half an hour, doctor. Really? Half an hour? Yeah, okay. So how long do you think, you know, if you were going to show me by walking across the room, you know, do this. Right, that was about 4 seconds. Oh, it seemed like half an hour, doctor. Right? Get the history, because the history is often whacked. Okay, totally. So you've got to penetrate with these. Go. What is it? What causes it? Are there specific conditions to look out for? Who do we admit? So this is the formal definition of an Alte. This is the fluffy bunny part of it. It has to be frightening to the observer. You know, if something like this happens to your child, and this is your first child, do you think it's going to be frightening? Absolutely. But that's part of it. Then the bits that we really get worried about are, there has to be apnea. There has to be a colour change and a change in muscle tone, usually limpness. And then there's some choking or gagging, and the observer feels that the infant has died once it happens at that point. The things we have to ask for are, did the child stop breathing? Was there a colour? Did they turn blue? Did they go limp? And was there any choking or gagging? That's all part of the definition. And I'll show you why all of this is important. Like syncope, it's not a diagnosis. It's a symptom. And we've got to find out what's caused it. What isn't it? It's not SIDS. About 10% of SIDS kids, though, will get some form of apnea. When they did the Back to Sleep program in the 90s, it didn't affect Alte rates at all. SIDS kids tend to come in between midnight and 6 a.m. in the morning, whereas Alte kids tend to go at the other time of the day. And they have a different set of risk factors. So it's not SIDS. It's not a disease of older children. It occurs in kids less than 2 months old most of the time, but it tends to not occur in kids greater than 6 months old. Okay? So 3/4 of the kids had Alte were less than 2 months old, but only about 1/4 of the kids with SIDS were in that age group. Okay? So it's a disease of the young, and it doesn't tend to happen overnight. Babies can have apnea lasting up to 20 seconds, and it's normal. Okay? We just don't know whether it was normal in that particular case, and so we have to link it with something else. And what we link it with is colour, tone change, heart rate, all of those things. So what are the causes? There are a lot of studies being done on this. And you tend to find that gastro-oesophageal reflux disease, you see it up the top right-hand corner there where I've kind of highlighted it. Some sort of respiratory infection, seizures, UTI tend to come up all the time. What was interesting in this study, and certainly other studies like it, was that under 2 months with a normal clinical examination and a lactate of less than 2 millimole per litre, none had a recurrent Alte. None were found to have a definitive diagnosis, but nothing bad ever happened to those kids. And so a normal clinical exam and a lactate in some of these studies is being done. So the results of this study and a lot of other studies, you will find they'll come up with the fact that gastro-oesophageal reflux disease, GORD, is one of the big causes, pertussis, a lower respiratory tract infection, seizures, and a UTI. And there's been a lot of these sorts of studies done. And let's have a look at these causes. Let's have a look at each one of them individually. Gastro-oesophageal reflux disease occurs up to about 30% of Alte is attributed to it. And certainly it tends to be increased in kids that have GORD, but it's not directly correlated with it. So you've got to be a little bit careful. If you have gastro-oesophageal reflux disease, it doesn't mean that you had an Alte. And if you had an Alte, it doesn't mean that it was a result of gastro-oesophageal reflux disease. Okay? Because gastro-oesophageal reflux disease causes very similar symptoms of the gagging and the choking, and they can potentially become a bit apneic. But you've got to start thinking about all those other things, the turning blue and the limpness that goes with it as well. Pertussis. 1% of all Altes are attributed to pertussis. Any child with pertussis and apnea must be admitted. The very young children have a significant mortality rate. And the kid may appear very well between those coughing bursts. RSV. So they can present with a cough and nasal congestion and fevers. Any kid with RSV and an episode of apnea should be admitted. This is documented in the literature. Now, these have a higher mortality rate. These are ones that scare me because they've got RSV, they've had an apneic episode, they actually look okay when they come in to see me. But because it's been proven to be associated, let's admit these kids. If they've had a seizure, do we admit them? Well, not always. If they've got a fever, and I'm very happy that it's a simple febrile convulsion, I don't admit. If they come back a second time and they've had a second febrile convulsion during the day, I don't necessarily admit if mum and dad are happy. Okay? They come back a third time, I don't necessarily admit. Okay? It's a simple febrile convulsion. Once they're there the third time, you just start to shake a little bit in your boots and you worry a little bit, and you might just keep them in the ED just long enough for your shift to be coming to an end, and you'll hand them over to somebody else. You just watch them. If you're at all concerned, just admit them, okay, because you don't want to commit. So it's a tactic I use all the time. Do we admit seizures? Look, 5% of these will go on with having some sort of formal seizure complex. I don't tend to admit. UTI and sepsis, urine should be taken in all of these kids that present, because about 8% of them will have a UTI. That's a significant yield for a very simple test. Now, it can be a significant test. And having been somebody that's done suprapubic aspirates on both of his children when they had a UTI, because guys couldn't get it, it's quite traumatic when you're a parent, watching somebody do a suprapubic or putting in a catheter in your child, okay? So, it's not as simple as that. So clean catch specimens, how do we feel about that? I love it. I love watching the parents holding that cup. It gives them something to do, waiting for the kid to pee, blowing on the kid's perineal region, doing all this weird stuff, right? How about a bag? People use bags here to collect urine. It's all been poo-pooed. I kind of feel, I don't mind bags as long as I do a real good clean of the child and I get a good specimen and I send it off and there's no squams in there. I still kind of consider a bag okay. But I'm not going to wait forever, and I'd rather do an in-out catheter and get the urine and let's get on with it. And I know there have been some studies done that have shown that no matter what you get with bags, it doesn't make any sense, but I don't like those studies, so I'm going to do what I think's right. How about this one? Serious bacterial infection in kids 60 days or younger with an apparent life-threatening illness. The rate of serious bacterial infection, SBI, in kids less than 60 days is about 6.7%. I'll show you that in the febrile child later. I'll show you how the rate of serious bacterial infection decreases in the first few months of life, how it occurs. So you've got a significant rate of serious bacterial infection. Other things you've got to think about are, is this non-accidental injury? Okay, you've always got to have that in the back of your mind. Is this some kind of metabolic cause? And I start to lose interest at this point. And the only blood test I know is ammonia. I do know lactate, but I do know ammonia. And there's all these magnificent diseases that people come down to where we could have MCADD. So I thought of that. MCADD, he could have MCADD. Have you done the ammonia? Yes, we have. We've done the ammonia. And what did he have that made you think of it to do the... I don't know. I just did the ammonia, all right? But I did the right thing. Okay, so... But these are kids that can't break down fatty acids, all sorts of issues occur, and they get abnormal LFTs, ammonia and lactate. Ammonia and lactate in children seems to be, in very young children, may potentially be not a bad blood test to do. And as somebody that was quite adverse to doing any sort of investigating, I'm starting to lean towards doing a couple of these tests now. Breath-holding spells. Who's ever seen a breath-holding spell? Okay, all right. So these are terrifying, and the child gets apneic, looks like they're having a seizure, and then they die, basically. That's the way it looks. So this is the way it was described. The pale spell was described. It happens in kids when they're startled, they open their mouth, they try to get out, they basically, Valsalva themselves, they can't get anything out. So this is how this guy described it. An unsteady toddler and his own trips and falls. His mother hears the bump. So how many times have kids come in saying, oh, I heard him fall, they obviously heard the bump. And the first question we ask is, did he cry immediately or not? We're concerned about loss of consciousness. But this one says, no succeeding cry, hurries to him. She finds the child lying deathly still, eyes fixed upwards, lips dusky. She lifts him, he abruptly stiffens into rigid extension, jaw is clenched, hands fisted, gives a few jerks, and after what seems an age, but in fact less than a minute, relaxes limply with an absent, far-away look. He then opens his eyes and at once recognised by the cries a little, drifts off to sleep and is pale. He can't cry. Get the history of exactly what happened. It's very important. This kid's going to need an EEG, of course, make sure he hasn't had seizures, and he also needs an ECG to make sure he hasn't got something like prolonged QT. So we heard about the Romano ward and all that, prolonged QT, because he could be having seizures secondary to prolonged QT. Who to admit? Who do we admit when they come in and we're a bit concerned that it might be? Well, if you're a bit concerned, admit them. Okay? Get peds to see them and admit them. If you're concerned, if the parents aren't coping, admit the child. Don't be concerned about that. Our job is not to not to kick people out of hospital. Our job is to treat them. Okay? And so, if you call the peds registrar and they say, I'm pretty convinced it's not an Alte, just send them home. Say, numbnuts, I'd like you to come down and see the patient, thank you. Okay? Nobody should give you an instruction on the phone that might suggest that you send somebody home and they have an adverse outcome without them coming to see that patient. Okay? And we shouldn't really be doing CAT scans at the drop of a hat. People say, the surgeon says, well, can you do a CAT scan? Then I'll come down. So you come down and see if you need the CAT scan. Okay? Who do we admit? This is a good study that was done. There were small numbers, but all of these studies have small numbers in them. Less than 1 month with multiple Altes. So if you had more than one of these episodes, just admit them all. Okay? And if they have one in your emergency department while they're there, they get automatically admitted. So here's my approach. If a child is premature, I admit them. If they're less than 1 month, I admit them. If they've had more than one of these episodes, admit them. If they've got respiratory symptoms and they've got pertussis or RSV and they've had an apneic episode, admit them. If there's any suspicion of non-accidental injury, if the child is in any way toxic or unwell looking, that goes without saying. And if the parents are distressed and they're not coping, admit these children. But the definitive indications for admitting potential Altes are RSV, pertussis and apnea, multiple episodes and very, very young age. What about the others? Do we work them up? What do we do? How far do we go? And there's been studies done on this that have looked at multiple workups and they go a little bit overboard. And it seems that there's a small group of children where lactate at a younger age, or lactate in this age group, maybe helps us discern who might be able to go home and who might not. I think the clinical picture is still the most important picture. In a child that's potentially had an Alte and is well looking, there's no other signs of anything else, there is an instance, as we said, of serious bacterial infection, so you do need to do at least a minimum of a urine. Remember, about 8% of them have a UTI, and you might need to do a chest x-ray, especially in the child that might have some lower SATs. We'll talk about febrile kids and chest x-rays in a minute. If there's no fever, if there's no cough, if they don't look like they've got any viral illness, if a child looks very well, self-terminated, and it occurred whilst feeding, and they've got none of my admission criteria, and everything else is normal, they go home. How many kids do you think I send home with a possible Alte, based on the number of criteria that I've included in there? Very few. Gastro-oesophageal reflux disease is not as responsible for Alte as we think. Okay? Be very careful not to attribute it to gastro-oesophageal reflux disease. Prematurity is a major risk factor. Respiratory disease needs admission. If a child is well, they're usually well, but this is the problem. It occurred in a situation where I wasn't there to observe it. If it occurs in front of me, I feel better because I understand what's happened. So this is an 8-month-old child and they've had a potential respiratory issue, that case 1. 8 months is a bit old for Altes. So just on that age group, you'd have to consider that this is not an Alte. In the second one, this is a young child. It terminated, and it terminated whilst the child was feeding. No cough, no respiratory symptoms. I check the vitals, I do a pulse ox, I do an ECG, and I observe this child in the emergency department if I can. But the age is concerning me here. The fact that it happened through feeding, don't be tricked into thinking that this is a gastro-oesophageal reflux disease. And this child, for me, because he went lip and he went blue, is going to come in. There's no question. The other one I will also observe in the ED, and I might send them home unless there's a respiratory issue. All right. Thank you very much. Apparent life-threatening events. Let's go on. No clapping. Let's keep going. Okay.